Okay. So welcome to the Central South Stroke Network's Fall Education Series focusing on stroke and the young patient. Each webinar is recorded and will be posted to the Central South website. Today is the third of our series. I ask you to please submit any questions using the Q&A function, and Dr. Nair will address questions at the end of her presentation. And Rhonda Whiteman, Regional Stroke Best Practice Clinical Nurse Specialist, will now introduce today's speaker.
Good morning, or I guess good afternoon, everyone. It's my pleasure to introduce Dr. Samiti Nair, who is the Assistant Professor of Medicine at McMaster University and a vascular and general neurologist at Hamilton Health Sciences and St. Joseph's Healthcare, Hamilton. Dr. Nair completed her residency training in neurology at the State University of New York and a fellowship in vascular neurology at New York Presbyterian Columbia University in New York in the United States. Dr. Nair has a keen interest in sex differences in stroke and vascular disorders. And so it's my pleasure to hand over to Dr. Nair, who will talk about stroke or pregnancy-associated stroke. Thanks.
Thank you, Rhonda. I appreciate that. So yeah, I will be speaking on pregnancy-associated stroke, which is quite a vast topic, and I will try and cover a majority of it, I guess. So here's my outline. I will speak on the incidence and prevalence of pregnancy-associated stroke. I will try and highlight traditional and pregnancy-specific risk factors. We will then speak on mechanism of pregnancy-associated stroke, as well as look at special populations that have further increased risk of pregnancy-associated stroke. I will end on secondary stroke prevention measures for this population, as well as outcomes in pregnancy-associated stroke. Pregnancy is defined as 40 weeks gestation. The puerperium period is 6 weeks post-delivery. A pregnancy-associated stroke, also called maternal stroke, is a stroke, ischemic or hemorrhagic, which occurs during pregnancy or postpartum. The incidence of stroke has been rising among the younger population, including pregnant women. Pregnant women will have up to a 3 times greater risk of stroke versus non-pregnant women. For example, the incidence of stroke during reproductive age can be as high as 20 per 100,000. But in pregnancy and puerperium, that number can rise up to 34 per 100,000. The WHO identifies stroke as one of the 10 leading causes of death in women of reproductive age in low, middle, and high-income countries. A significant portion of these strokes are occurring in pregnancy. Postpartum mortality is high, up to 10%, and it's the 7th most common cause of long-term disability after pregnancy. Women have particularly increased risk of stroke in the peripartum and postpartum period due to traditional stroke risk factors, as well as pregnancy-specific conditions. The nationwide inpatient sample, which is the largest inpatient database in the US, found up to 90% of strokes occurred at the time of delivery or postpartum. A more recent 2018 review of all maternal strokes in the state of New York reported 70% were occurring postpartum. The risk of stroke associated with pregnancy can be immediate, but it can also occur later in life. A pregnancy-associated stroke can also influence a woman's health past this reproductive event, as well as decision-making on future pregnancies. A Canadian retrospective study included women that were antepartum, peripartum, and postpartum between 2003 and 2016. Out of 4 million pregnancies, 524 strokes were identified. Postpartum strokes were the majority. Traditional stroke risk factors, as well as pregnancy-specific conditions, were identified. This is a table from that study. Multiple risk factors and associations were identified, but the strongest association was for maternal age. The authors reported that the worrisome part is that these numbers are growing. In 2003, the rate of stroke during pregnancy was about 11 per 100,000. That number rose to about 17 per 100,000 in 2015 to 2016 in Canada. The risk of the rise in incidence of stroke during pregnancy in Canada, the authors argued, was likely due to maternal age that has been increasing, and also other stroke risk factors such as hypertensive disorders or heart disease. Globally as well, we see a similar trend. There's been an older maternal age. Hypertensive disorders have increased in high-income countries, again, contributing to pregnancy-associated stroke. Thus, identification of these risk factors and close follow-up of this population is indicated. Traditional stroke risk factors have been increasing in the young population. These include hypertension, diabetes, and obesity. And there's also advancing maternal age at the time of birth. All of these are likely contributing to pregnancy-associated stroke risk. Heart disease, for example, can be congenital or acquired. In the 2019 study I mentioned earlier, found that there was up to a 40 times greater risk of maternal stroke in women with congenital heart disease. Advances in medical treatment options and these women living into adulthood means that more of these women are choosing pregnancy. Globally, however, acquired heart disease accounts for a greater proportion of maternal stroke. There is a rising maternal age, and that's been strongly associated with pregnancy-associated stroke. The absolute risk of maternal stroke was found to be lower in those less than age 34 and highest amongst women over the age of 40. More women are also choosing careers and delaying pregnancy. For all births, the average age of mothers at childbirth has been over the age of 30 since 2010. And this trend is seen globally. This is a figure from a US study looking at the incidence of acute stroke or TIA as a function of maternal age. And we see similar trends. Stroke incidence increases with advanced maternal age. Another risk factor is patent foramen ovale. This is a persistent communication between the left and right atria. Pregnancy and puerperium are associated with a high risk of venous thromboembolism, in fact, a 5-fold increased risk versus a non-pregnant patient. PFO-related strokes, unlike other risk factors for stroke, usually cause a stroke in the first or second trimester. A 2016 study compared maternal stroke due to PFO versus other etiologies. They found that women with PFO-related strokes were more likely to have other risk factors, such as high-risk PFO morphology, hypercoagulable state, migraine with aura history, or multiple gestations. Hypercoagulable testing should be considered in those that are pregnant with a known PFO. It's unclear at this time whether a woman who has a PFO but no history of thromboembolic events should be treated prophylactically, either with antithrombotics or closure. As per the Canadian Stroke Best Practices Guidelines, PFO closure is not recommended during pregnancy for secondary stroke prevention. Aspirin 81 milligrams is considered first line. And those that have a PFO and are at high risk of venous thromboembolism should be started on low molecular weight heparin. Tobacco use in pregnancy can vary globally and can be as high as 8%. Secondhand smoking is probably higher. Tobacco can double the risk of stroke through its direct interaction, but it can also indirectly increase stroke risk by its effect on blood pressure. A Swedish cohort study reported that the relative risk of maternal stroke in smokers was almost 2.5 times higher than those that were not smoking. Smoking in the second and third trimester can increase the risk of preeclampsia, and nicotine is the likely culprit. Fetal exposure can also increase the risk of stroke later in life in these kids. The atherosclerotic risk in young adult study out of the Netherlands reported that tobacco likely crosses the placenta and thus impacts the fetal cardiovascular system. Infection in pregnancy and postpartum can also increase maternal stroke risk. A case-controlled study using inpatient data from 3 different states in the US found an almost 2 times higher risk of peripartum stroke in women who were admitted with infection at time of delivery. Genitourinary infections and sepsis carry the highest risk, and this risk persists even after controlling for confounders. This is likely due to increased inflammatory cytokines, which lead to platelet aggregation and impaired endothelial dysfunction. Infections can also provoke cardiac arrhythmia, predisposing to clot formation, and dehydration can also induce thrombosis. And the presence of preeclampsia with infection can triple this risk. In the setting of preeclampsia-associated inflammatory changes and puerperal hypercoagulability, a superimposed infection can trigger stroke by further exacerbating the inflammatory response and coagulopathy. A urinalysis should be considered with blood pressure checks in the preeclamptic patient, yet the use of prophylactic antibiotics is unknown and can be considered in future trials. Intimate partner violence is more prevalent during pregnancy, including physical abuse. Strangulation, for example, can cause cervical artery dissection, thus increasing stroke risk. As per the Canadian Stroke Best Practices Guidelines, aspirin is a first-line therapy for cervical and vertebral artery dissection. Method of delivery is not standard for all those with a dissection. C-section is case-based and should be discussed with the patient's obstetric team. All women, however, should be screened for abuse at their routine visits. Pregnancy specific risk factors are many, and most of them are listed here. The ones in bold require further discussion. Hypertensive disorders of pregnancy, including preeclampsia and eclampsia, gestational diabetes, hyperemesis, which can lead to hemoconcentration and increased risk of cerebrovenous sinus thrombosis. Method of delivery, there is a higher risk of stroke following C-section, both the peripartum and postpartum period. Assisted reproductive technology, which has been gaining popularity in the recent years. Amniotic fluid embolism in patients with PFO can cause multiple infarcts. And other pregnancy complications, such as preterm delivery, placental abruption, and stillbirth, can increase the risk of future cardiovascular and cerebrovascular disease. Hypertensive disorders of pregnancy can occur during pregnancy or in the postpartum period. A retrospective study of readmissions for stroke within 60 days of delivery found that women with chronic hypertension or hypertensive diseases of pregnancy were at highest risk of postpartum strokes, and most of these would occur within 10 days from discharge. Chronic hypertension can shift the cerebral autoregulatory curve, but it's not associated with loss of dynamic cerebral autoregulatory capacity because of rapid adaptation of the vasculature. In hypertensive disorders of pregnancy, this autoregulatory capacity is lost. Preeclampsia is a multi-system hypertensive disorder characterized by widespread endothelial dysfunction and immune dysregulation. It's one of the most common risk factors for stroke in pregnancy and postpartum and can affect up to 8% of pregnancies. When it occurs postpartum, the highest risk is within 48 hours from delivery. Up to 36% of women with a pregnancy-associated stroke have comorbid preeclampsia. Preeclampsia increases the risk of stroke during puerperium up to 6-fold. Preeclampsia can cause systemic inflammation, endothelial injury, platelet activation, and hypercoagulability. I could probably speak on preeclampsia for the rest of this talk, but I won't. The etiology of preeclampsia is not fully understood, but placental factors are likely implicated. In the first stage, inadequate placentation and inadequate remodeling of spiral arteries occur. In the second stage, there is release of cytokine and placental factors, which lead to endothelial dysfunction and other complications. Preeclampsia causes neurovascular dysfunction. The neurovascular unit is a complex of cells and proteins, which maintains the blood-brain barrier and regulates cerebral blood flow. In preeclampsia, with the release of inflammatory cytokines, there is impairment in potassium channel-mediated vasodilatation, and vasoconstriction, which are critical mechanisms for neurovascular coupling and cerebral autoregulation. This leads to cerebral perfusion pressures being elevated in women with preeclampsia, even when hypertension is treated. A 2005 case series, for example, reported that women with stroke and preeclampsia actually didn't have very elevated pre-stroke blood pressures. Yet most of these women had intracerebral hemorrhages, despite these blood pressures not exceeding 160/110. Thus implying a breakthrough of autoregulation below the classic 150 autoregulation threshold. Preeclampsia also alters coagulation pathways, thus increasing fibrin, activating platelets, and impairing fibrinolysis. The acute effects of preeclampsia include RCVS, intracerebral hemorrhage, ischemic stroke, and subarachnoid hemorrhage. The risk of acute cerebrovascular disease in preeclampsia is as high as 1 in 500 deliveries. Contrast that to up to 30 in 100,000 pregnancy-associated strokes. The highest risk of acute neurovascular compromise is at delivery and up to 2 weeks postpartum. This risk will be further increased with concomitant infections, chronic hypertension, and other hypercoagulable disorders. Aspirin for stroke risk reduction in the preeclamptic is recommended. And it should be noted that the risk of stroke is later in life as well. How preeclampsia affects stroke risk later in life is not fully understood, but it is an independent risk factor for future stroke in women, particularly in the middle-aged. Prevalence of cardiovascular risk factors and abnormal vascular markers are higher in the preeclamptic woman. Women with preeclampsia are more likely to have higher insulin levels even years after. Women with a history of preeclampsia, even decades prior, were found to have higher diastolic blood pressures than women without a history of preeclampsia. But even after controlling for traditional risk factors, there's a higher cardiovascular and cerebrovascular disease seen in preeclamptics versus normotensive pregnancies. This risk is higher still with early onset preeclampsia. Endothelial dysfunction and impaired cerebral autoregulation are the likely mechanisms. Thus, identifying other modifiable risk factors that put these women with preeclampsia at highest risk is indicated. This is a nice slide that summarizes both the acute and chronic effects of preeclampsia. Short-term complications can include intracerebral hemorrhage, increased blood-brain barrier permeability, cervical artery dissection, or ischemic stroke. Long-term effects include increased carotid intima media thickness, which is a marker of atherosclerosis, white matter hyperintensities, vascular dementia, and cerebral small vessel disease. Gestational diabetes can also be a risk for maternal stroke. The data, however, is limited. A case-controlled study from 2012 reported that there was an up to 20-fold increased risk of stroke in women with gestational diabetes. 50% of these women will go on to develop diabetes type 2 within a decade of their pregnancy. Gestational diabetes will also be a risk factor for developing cardiovascular and cerebrovascular disease later in life, even when we control for subsequent diabetes and other traditional risk factors. Peripartum cardiomyopathy and left ventricular dysfunction can occur in the last month of pregnancy or within 5 months postpartum, even in those women without history of cardiac disease. Amniotic fluid embolism can occur during labor, and with a PFO with right to left shunting, multiple infarctions can result. Preterm delivery can increase the risk of long-term stroke many years after. A national Swedish cohort study of over 2 million women who had had a singleton delivery were followed for multiple decades. They reported that preterm delivery was associated with hemorrhagic and ischemic stroke, and this risk remained up to 40 years later. The highest risk was in the first 20 years from delivery. Each additional week of pregnancy was associated with a 7% lower risk of stroke later in life. This was independent of other covariates, such as hypertensive disorders of pregnancy. Recurrent preterm deliveries further increase this risk. The author suggested that preterm may trigger endothelial dysfunction, causing atherosclerotic buildup and stroke risk later in life. Assisted reproductive technology has been gaining much popularity over the last few years. This includes in vitro fertilization, artificial insemination, surrogacy, and fertility medication. IVF is the stimulation of ovaries by fertility medications to produce follicles, which are then fertilized in the lab and transferred to the uterus. IVF involves use of exogenous hormones to achieve cycle control, stimulate ovaries, and successfully implant using supraphysiologic estradiol levels. Studies have already shown exogenous estrogen can cause a prothrombotic state. Thrombosis can occur in IVF cycles in up to 0.2% of IVF cycles. But when complicated by ovarian hyperstimulation syndrome, this incidence can increase up to 10%. The majority are venous, but arterial thrombosis can occur as well. So what is OHSS? There are two forms. One is the early form, which is due to exogenous HCG administration, and the late form, which is due to endogenous HCG production during pregnancy. Excess HCG causes overstimulation of the ovarian follicle, thus increasing ovarian size. It also causes secretion of VEGF. This results in venous stasis and hypovolemia and hemoconcentration, which then increases ischemic stroke risk. The incidence of OHSS may be 6% or perhaps even higher because it is not readily detected. Thromboembolic complications are seen with the severe form and are still rare, less than 2%. Most commonly, these severe forms and thrombotic complications occur in the first trimester, typically presenting within 10 days post-exogenous HCG administration. Risk factors for the severe form of OHSS include younger age, higher number of induced follicles, polycystic ovarian syndrome, hypothyroidism. Interestingly, pre-existing thrombophilic disorders were not associated. Supraphysiologic estrogen levels and leukocytosis, indicating endothelial injury, are often observed and may be contributing to the risk of thromboembolic complications. The pathophysiology of OHSS is still unclear. Best practice has not been established. Some argue thrombophilia screening may be indicated, but we don't know the clear benefit, and it's cost prohibitive. Some obstetricians will opt for heparin therapy as soon as OHSS is diagnosed. When there's acute neurological symptoms, however, heparin with aspirin is recommended. Also recommended is supportive therapy, including hydration, albumin administration, and electrolyte correction. Further, some have argued that infertility may be a consequence of underlying vascular disease. A 2017 prospective cohort study compared successful and unsuccessful ART and found that women who failed assisted reproductive technology over an 8-year follow-up were more likely to have an adverse cardiovascular event, regardless of how many IVF cycles they received. They argued that infertility may reflect an underlying predisposition to vascular disease, and pregnancy may unmask this predisposition in women undergoing artificial reproductive technologies. The mechanism of maternal stroke involves probably changes in coagulation factors, connective tissue changes, cardiac and hemodynamic changes, and immunologic and inflammatory changes. There are multiple changes that occur in the maternal coagulation pathway. The green arrows represent those that decrease thrombotic risk, and the red arrows indicate increase in thrombotic risk. This is done so as to prevent exsanguination during the deliveries in pregnant women. Coagulation factors and fibrinogen levels will rise up to 2-fold in pregnancy. Protein C and protein S are also altered, thus increasing the risk of thrombosis. Fibrinolysis also decreases during pregnancy. plasminogen activator inhibitor 1 and 2, which is released by the placenta, can inhibit TPA and urokinase. Higher estrogen levels also upregulate clotting factors and downregulate inhibitors of coagulation. Total intravascular volume is significantly higher in pregnant versus non-pregnant women. High levels of estrogen will increase venous compliance and reduce systemic vascular resistance during pregnancy. Progesterone and relaxin will increase during pregnancy and further contribute to systemic vasodilatation and increased venous capacitance. Increased compliance along with hypervolemia will promote venous stasis, predisposing to venous thrombosis, especially when coupled with mechanical compression of iliac veins by the uterus and delivery-associated endothelial damage. Hemodynamic changes occur during pregnancy as well. The heart will undergo temporary remodeling, predisposing to intracardiac thrombus formation. There's a mild four-chamber dilatation where the right is slightly larger than the left. Structural changes also increase the risk of atrial arrhythmias and right to left shunting, thus increasing risk of cardioembolic stroke. The growing fetus puts high demands on the maternal cardiovascular system. At 6 weeks, the high levels of estrogen stimulate renin production by the kidneys, uterus, and liver. The increased renin will then stimulate aldosterone production, leading to increased total body water. Plasma volume will increase by 45%, but red blood cells by only 30%. This results in physiologic hemodilution of pregnancy and a decrease in hemoglobin concentration, thus creating anemia. How anemia increases stroke risk is still not clear, and how anemia of pregnancy contributes to maternal stroke risk and recovery is still unknown. But we do know that it may change how effectively oxygen is delivered to the brain. Anemia can also impair stroke recovery. However, the clinical utility of treating anemia in pregnancy with iron supplementation is currently unknown. Immunologic inflammatory changes also occur during pregnancy. For example, in the first trimester, high levels of pro-inflammatory T helper cell activity will lead to elevated levels of interleukin-6, CRP, and TNF-alpha, all of which can then increase risk of thrombus formation and stroke. Some special populations are at further risk of pregnancy-associated stroke and require further discussion. I've chosen to speak of 3 of them here. This includes migraine, moyamoya syndrome, and antiphospholipid syndrome. Although highly prevalent in women of childbearing age, migraine headaches will often improve during pregnancy. But a high estrogen state, such as pregnancy, can increase the risk of migraine with aura, stroke, and venous thromboembolism. Migraine-associated stroke risk is higher in the perinatal period. In fact, migraines in pregnancy can increase the risk of stroke by 3-fold. The highest risk of stroke is an active migraine, where the odds ratio have been reported as high as 31. History of migraine can also increase the risk of gestational hypertension, preeclampsia, and vascular diseases later in life. This table is from a US population-based case-controlled study that looked at the association between peripartum migraine and vascular diagnoses. They used nationwide inpatient sample data, and over 18 million pregnancy-related discharges were identified. Of these, 34,000 were migraineurs. Peripartum migraineurs had a 15-fold increased risk of pregnancy-associated stroke, and ischemic stroke had an even stronger association. Hypertension was also strongly associated. As a result, a 2020 study then looked at the extent to which hypertension disorders are mediating the association between migraines and maternal stroke. A California-based retrospective study looked at over 26,000 women with migraine during pregnancy and delivery. Of these, 843 experienced a stroke in pregnancy or delivery or postpartum, and ischemic stroke was the predominant form. Migraine with aura was associated with multiple stroke risk factors such as hypertension, diabetes, tobacco use, but hypertensive disorders had the highest association. They reported 25% of maternal stroke cases that were associated with migraine were attributable to hypertensive disorders. This table is from that study, and it shows the adjusted risk ratios highlighted in green and the proportion mediated by hypertensive disorders highlighted in yellow. Women with migraine during pregnancy were more likely to have hypertension, a stroke at pregnancy or delivery, or a stroke postpartum. Hypertensive disorders mediated 21% of stroke risk in pregnancy and 27% risk in stroke postpartum. The mechanism of migraine-related stroke in pregnancy is likely centered around endothelial dysfunction. Migraine activates the endothelium, and recurrent migraines lead to endothelial dysfunction. Other cardiovascular risk factors, such as hypertension and diabetes, tobacco use, dyslipidemia, also contribute to endothelial dysfunction. In pregnancy, where a woman has a procoagulable state and these physiological changes, along with migraine, can thus lead to infarction. Aspirin during pregnancy can be considered for women that have high risk of stroke, including those with migraines. Counseling for female migraineurs before conception to minimize other stroke risk factors should be considered. Women with a history of prior cerebrovascular disease should avoid vasoconstrictive medications such as triptans. And a new onset of headache in pregnancy and postpartum should always be adequately worked up to rule out vascular causes. Moyamoya is a progressive steno-occlusive cerebrovascular disease which affects proximal arteries and predisposes to both ischemic and hemorrhagic strokes. Moyamoya is more common in women and presents in early adulthood in the same age group as those choosing pregnancy. A 2018 systematic review of 54 articles related to moyamoya in pregnancy reported that a diagnosis of moyamoya in pregnancy mostly occurs in the second half, and the majority of these patients are presenting with intracerebral hemorrhage. They also have high rate of both maternal and fetal morbidity and mortality. When diagnosed postpartum, it usually presents as a stroke occurring within 3 days of delivery and mostly ischemic. However, moyamoya is not a contraindication to pregnancy if hemodynamics are managed. Blood pressure control is critical, and we must avoid hyper as well as hypotension. Bypass prior to pregnancy or a standardized method of delivery is not recommended. Rather, select patients may benefit. For example, for C-sections, which can induce hypotension, this may be more adequate for patients that have high risk of intracerebral hemorrhage, such as those with hypertensive disorders or history of prior hemorrhage. For revascularization, a retrospective study of moyamoya during pregnancy and puerperium suggested that those that have frequent ischemic events, along with imaging that shows reduced cerebral blood flow, predict higher risk of neurological deterioration during pregnancy, and surgical revascularization in these patients may be helpful. Antiphospholipid syndrome is an autoimmune disorder where antiphospholipid antibodies can increase arterial and venous thrombosis and pregnancy complications. 1 out of up to 50 APS pregnancies is complicated by thrombosis despite treatment. It may be even more common than that. Most common presentation is first trimester pregnancy loss, but the strongest association with antiphospholipid syndrome is late pregnancy loss. Placental complications can also occur, leading to preterm delivery, which, as we've discussed, can increase risk of stroke later in life. The Canadian Stroke Best Practices Guidelines recommend aspirin plus or minus anticoagulation for stroke prevention. When anticoagulation is needed, low molecular weight heparin is the preferred treatment because of its predictable pharmacokinetics. Other treatments that have been looked at but yet don't have a clear role in stroke prevention include plasma exchange, IVIG, and steroid therapy. Pravastatin may actually reduce the preeclampsia risk in this population, but requires further study. Artificial reproductive technologies are more likely to be successful in APS women with antithrombotic use. Again, hinting at perhaps infertility is a consequence of vascular disease. Secondary stroke prevention and pregnancy-associated stroke is limited. A lot of this information is obtained from the Canadian Stroke Best Practices guidelines, as well as other reviews and articles. In women where antiplatelet is recommended, aspirin 81 milligrams is preferable. Unlike other NSAIDs, aspirin has not increased the risk of premature closure of the ductus arteriosus or fetal renal injury. Low-dose aspirin can also be used in breastfeeding because it is not excreted into breast milk. Warfarin, however, is teratogenic and should be avoided in the first trimester, particularly in weeks 6 to 12. The recommendation is to use alternate agents where anticoagulation is absolutely necessary, such as in mechanical heart valve patients. Use of DOACs is unknown in pregnancy and breastfeeding, and generally the recommendation is to switch to low molecular weight heparin. However, a 2020 retrospective cohort study reported that there may not actually be a high risk of embryotoxicity with DOAC use. Clearly, this requires further study. This is a summary slide of options for switching a patient on DOAC to various treatment regimens. Regardless of the treatment regimen that one chooses, careful monitoring and follow-up is necessary. Some will argue to start low molecular weight heparin prior to conception. That may not be as feasible because compliance becomes an issue. Women will have to self-inject for 9+ months, which can be problematic. The commonly used medications in secondary stroke prevention, blood pressure management are not recommended due to fetal complications causing kidney injury and low amniotic fluid. Rather, nifedipine, labetalol, and methyl-dopa are the recommended oral blood pressure agents. The target blood pressure in this population is less than 140/90. In terms of lipid management, lipid levels are unreliable due to the physiologic changes in pregnancy. We don't know the safety of statins in pregnancy and lactation, therefore they're not recommended. Diet and exercise is the primary treatment recommendation. Pregnancy-associated stroke outcomes data is very limited. In general, women have poor outcomes. They're less likely to be identified in the hyperacute phase. They're also less likely to be thrombolized. There's up to a 13% lower odds of treatment in women when compared to men in both American as well as European studies. With regards to hyperacute treatment outcomes, historically, pregnancy has always been treated as a contraindication to treatment in an acute stroke. But studies show us that pregnant patients, when treated with thrombolysis or mechanical thrombectomy, have similar good outcomes versus those that are not pregnant. A 2016 study using the Get With the Guidelines stroke registry data reported that there were similar rates of reperfusion in a pregnant versus non-pregnant women. There were also similar rates of discharge to home after a stroke when treated. In regards to TPA, there may be a slight trend towards increased intracerebral hemorrhage with thrombolysis in pregnant women, but there is no significant major systemic bleeding or in-hospital deaths noted. In regards to mechanical thrombectomy, a 2021 study reported that pregnant women who undergo mechanical thrombectomy actually have lower rates of intracerebral hemorrhage and lower rates of poor functional outcome than the non-pregnant. Therefore, Canadian Stroke Best Practice Guidelines recommends that for thrombolysis, women should be treated based on maternal risk associated with an acute stroke. Alteplase does not cross the placenta, and it does not increase fetal bleeding risk, either intracranially or systemic. Bleeding risk, however, can be increased when an epidural is placed, and therefore close monitoring is required. With regards to mechanical thrombectomy, pregnancy is not a contraindication to angiography or to endovascular thrombectomy for large vessel occlusions. Ways to increase safety is abdominal shielding and limiting X-ray exposures. But despite these guidelines, a recent Canadian survey within the Canadian Stroke Consortium found a discordance between guidelines and clinical practice, where practitioners noted a hesitancy in treating pregnant women with thrombolysis and mechanical thrombectomy. Few studies have examined pregnancy-associated stroke morbidity. Women stroke survivors in general have poor outcomes when compared to men. They have poor quality of life, both physical and mental, more anxiety and depression, and more cognitive impairment. Similarly, pregnancy-associated stroke can also impair quality of life. Women experience residual fatigue, they have loss of mobility and speech, and more cognitive impairments. And it can even affect fetal and neonatal health. Pregnancy-associated stroke can also affect decision-making on future pregnancies. Pre-conception medical counseling should be offered to all pregnancy-associated stroke survivors. A 2000 study looked at the risk of recurrent stroke during subsequent pregnancies. The most common reason that women with a one-time pregnancy-associated stroke reported was avoiding future pregnancies was fear of recurrent stroke, residual handicap from the initial stroke, and medical advice from medical practitioners against pregnancy. But a history of stroke should not be a contraindication for subsequent pregnancy. Rather, counseling on underlying risk factors is what's needed. Of the 441 women that had a pregnancy-associated stroke in the study, only 13 went on to have recurrent strokes. And of those, only 2 were actually associated during pregnancy. And that was because of a known stroke risk factor, antiphospholipid syndrome. These patients need good follow-up. They need thorough investigations to ascertain the etiology and to maintain control of risk factors so as to minimize future risk. A systematic review looked at pregnancy-associated stroke and subsequent pregnancy and maternal health. They reported that those with an underlying predisposing condition were at the highest risk of pregnancy-associated stroke versus women that had a cryptogenic pregnancy-associated stroke. They also reported that 50% of women with a pregnancy-associated stroke went on to have subsequent pregnancies. The risk of recurrent stroke during pregnancy was in fact equivalent to that in non-pregnancy associated stroke. Pregnancy-associated stroke has historically had high mortality rates. A 2020 study reported that there was a 385 times higher mortality rate in pregnancy-associated stroke admissions versus other pregnancy-associated admissions. They used data from the nationwide inpatient sample, and over 37 million pregnancy-related hospitalizations were studied. They noted that over 2007 to 2015, the acute stroke rates actually didn't change, but mortality rates did decrease. So although the mortality rates are high, we are seeing a trend towards a decrease, and this is likely due to improved diagnosis and treatment options. So as to not end on a negative note about pregnancy and stroke, pregnancy may actually confer certain benefits in stroke prevention. Parity has mixed data. Some studies have reported a link between greater number of pregnancies and increased stroke risk, but that may actually be mediated through obesity. Some other studies actually report a lower future stroke risk. Animal studies have shown that there is acute and long-term protective benefits of parity after stroke. For example, multiparous mice had smaller infarct size and increased concentration of VEGF when compared with nulliparous mice. Greater post-stroke angiogenesis correlated with improved performance on sensory motor tasks as well as cognitive function. This difference remained despite weight gain, obesity, sedentary behaviors, or other metabolic risk factors. Breastfeeding may also lower stroke risk. It can reduce the risk of diabetes, hypertension, and heart disease. Using the Women's Health Initiative data, over 80,000 postmenopausal women were studied. Those with a history of breastfeeding for 1 or more months had lower stroke risk. And this was seen in multiple adjusted models when adjusted for other covariates. Postmenopausal women with history of breastfeeding had approximately 20% lower risk of stroke, even after controlling for smoking, BMI, age, and other risk factors. And women with 9 or more cumulative months of breastfeeding over their reproductive lifetime were less likely to develop hypertension, dyslipidemia, and metabolic syndrome. Longer duration of breastfeeding was also associated with lower risk of developing diabetes type 2 and reduced maternal postpartum weight. Breastfeeding rates vary by race and are lowest amongst the Black and Hispanic women in the US. These are also the same group that have higher risk of pregnancy-associated risk factors, as well as pregnancy-associated stroke rates. This benefit may be mediated through oxytocin and its anti-inflammatory effects. Further study is still needed. So there are potential benefits to a healthy pregnancy, but we need to study them further. Significant gaps remain in pregnancy-associated stroke outcomes, which need further investigation and identification. We also need potential solutions to address and improve the outcomes, as this is a young population which can have a significant burden on society and family if ignored. So, in summary, pregnant people are considered a young and healthy population. However, they're increasingly older at first time of delivery and more likely to have complex comorbidities. For example, more professional women will delay first-time pregnancy. They may be of financial means and may be seeking assisted reproductive technologies. The peripartum period represents a window of susceptibility when stroke risk is acutely increased, especially in those with pre-existing conditions, but also those that develop medical conditions during pregnancy. Peripartum and early postpartum periods have the greatest risk of stroke. Pregnant women with stroke benefit from hyperacute treatments, but there's still a hesitancy amongst practitioners in treating these patients. Pregnancy can be a teachable moment to help women and their partners control stroke risk factors. In-hospital mortality for pregnant and peripartum women with stroke is high, but the rate is decreasing, likely due to better identification and treatment. There is better identification and treatment in academic centers, and therefore, these types of patients should likely be treated in tertiary level academic centers. Major risk factors for pregnancy-associated stroke may largely be preventable. Appropriate counseling, monitoring, and aggressive prevention and treatment measures for high-risk pregnant women should be considered. A healthy pregnancy can have stroke prevention benefits. Remember, this is a young population with a high impact on their family as well as society. So future research is needed in the mechanism of stroke, the prevention that we can employ, and outcomes in pregnancy-associated stroke.
Thank you, Dr. Nair. So encouraging our participants to write and put questions in the Q&A. There is one there already. So I can read it to you, Dr. Nair. Is it common for a brain AVM to bleed in pregnancy?
Yeah, so that is a risk factor in pregnancy. There is a risk of increased rupture, and whether all of them should be treated prior to pregnancy is not known, and we can't identify all of them prior to pregnancy. There is some recommendations listed on the Canadian Stroke Best Practice website as well.
Okay, if anyone else, if you would like to take the option of raising your hand, that's also a possibility, and we can unmute you if that's a preference. Okay, so we do have somebody. Okay, go ahead.
Thank you, Dr. Nair and the team for the excellent presentation. My question is, I'm not sure whether it is related to the high risk for the stroke during pregnancy or postpartum, but we had a few patients with the postpartum having a neck pain and had a chiropractor treatment and end up having a stroke. Now, does that has any relation with the postpartum changes in the body and at the risk factor for the, the dissection, or, I don't know.
Well, there is hypermobility of joints that occur like during pregnancy. Whether that's been extensively studied, I don't believe so. But do remember, any kind of trauma may further predispose to thrombosis and endothelial dysfunction occurring more likely in a pregnant or postpartum woman, as opposed to somebody who's not pregnant. So it may be conferring a slightly increased risk of complications from, chiropractic manipulations or neck trauma. But it's not definitely just because of connective tissue disorders or joint disorders or mobility disorders, but rather the complex interaction between the coagulation pathways that are altered, as well as the other changes that occur in pregnancy.
Thank you.
Okay, we'll just wait for just another minute or so to see if anybody has any additional questions. Go ahead, Rhonda.
I just had a question with, when you look at women who have postpartum associated strokes, do we see any impact on pregnancy associated strokes? Any impact on the fetus as a result of the stroke?
Yeah, so there are studies. They're limited and because of time restraints, I didn't speak of them. But there are studies, especially European studies, that have looked at fetal health in pregnancy-associated stroke population. And they have shown that there is an increased risk of not only fetal complications, but also fetal cardiovascular and cerebrovascular health as they age into young adulthood as well.
Thank you. It's very interesting I think when you sort of that ongoing, more chronic risk of the cardiovascular risk was certainly something that was new information for me. So it's interesting that just recognizing that pregnancy associated strokes are a smaller proportion, that obviously the studies looking at the fetal health likely are smaller also. Thank you.
Yeah, and in regards to, menopause in the middle-aged women, already we have a higher risk, even when compared to men in that age group. And now when you add on other pregnancy-related changes that occurred and are further burdening our health at that age, it can be significant.
Thank you. So thank you again, Dr. Nair. Just excellent presentation, and just want everyone to know that an evaluation link has been sent out. It will be in your inbox already, and we would love for you to provide some feedback, which helps us as we continue to plan education. There are still 6 more sessions in our series on stroke impacting the young patient. And our next one will be on on October 25th, so next Tuesday, Dr. Fogarty will be speaking on neurocognitive impacts of stroke on the young patient. Okay, well, thank you again, and have a wonderful afternoon, everyone, and we'll see you next week. Stop sharing. Okay.